According to the American Cancer Society, there will be nearly 181,000 new cases of prostate cancer, and approximately 26,000 men will die from it in 2016. The learning objectives are to develop an understanding of the appropriate ages to begin prostate cancer screening at the varying risk levels, and to translate and interpret abnormal prostate exam findings and what diagnostic studies are appropriate. Prostate cancer is the malignancy of the prostate gland, and while its etiology is unknown, it is thought that a diet high in fat, familial genetics, and influence of hormones may contribute to its occurrence. It is the leading cause of cancer in men, and 40% of men older than 50 years of age have been found to have prostate cancer on autopsy. There is a 17% lifetime risk of prostate cancer, and risk increases with age, and it's most common after the age of 60. The pathophysiology of prostate cancer is believed to result from the accumulation of genetic abnormalities that affect androgen receptors on prostate tissue. It's a glandular cancer that initially forms in small clumps and can disseminate. Hematogenous and lymphatic metastasis may be found, as well as mets to the bone, lymph nodes, and bladder. These genetic abnormalities are characterized into three groups. The genetic predisposition to prostate cancer are seen to run in families, like with chromosome deletion. There's somatic mutations that activate oncogene mutation, and there's somatic mutations that deactivate tumor suppressor genes. The accumulation of these genetic mutations over one's lifetime provides the strong correlation with age and prevalence of the disease. Risk factors include a family history including first-degree relatives. Having a father or brother with prostate cancer more than doubles a man's risk for developing prostate cancer. African American men are also high risk and are twice as likely to die from prostate cancer than Caucasian men. A diet high in fat, particularly animal fat, exposure to cadmium nitrates and heavy metals, so our Vietnam vets that are exposed to Agent Orange, and also farmers and firefighters are at increased risk due to occupational chemical exposure. Smoking is also an added risk. While it doesn't increase the risk for getting prostate cancer, it is shown to increase the risk of dying from prostate cancer. Endogenous increased levels of testosterone is also a high risk area. There's much debate on the risks of this or if it's actually beneficial to have increased testosterone. Some research shows there's no correlation with high testosterone levels causing prostate cancers, and some subject experts actually believe that higher levels of testosterone may decrease the risk of getting prostate cancer. For prostate cancer screening, it is recommended that at the age of 40, for men with multiple first-degree relatives and prostate cancer history, to begin with the annual PSA and digital rectal exam. For those high-risk individuals, it is recommended to consider an annual PSA and a digital rectal exam beginning at age 45. And for all others, an annual PSA and digital rectal exam are recommended by the American Urologic Association to begin at age 55. For those who have a life expectancy of 10 years or less, no screening is recommended, and it shouldn't be offered as long as the patient is asymptomatic. Signs and symptoms of prostate cancer: subjective, they're often asymptomatic. They may have hematuria, acute urinary retention, difficulties voiding, back and hip pain radiating into the testicular area, and weight loss. Neurosymptoms may include the inability to sense touch, pain, and temperature in the perineal or scrotal area, lack of sensation of bladder distension. All of these are associated to epidural metastasis and cord compression. Objectively, upon digital examination, the prostate will feel hard. There may be palpable prostate nodules. We may find lymphedema and lymphadenopathy. A urinalysis may reveal a UTI or hematuria, and a CBC may reveal anemia secondary to the chronic hematuria. Diagnostic procedures that can be done: we can have a ultrasound of the prostate. We can do a PSA, which may be normal, but if it's elevated, it's usually greater than 10. Elevations in the alkaline phosphatase is indicative of metastasis. And we can do bone scans to rule out any metastasis. And these bone scans are usually indicated anytime we have a PSA over 20. We can do a CAT scan that will evaluate the size of the prostate and assess for lymph node involvement. For biopsies, a PSA value greater than 10 should be biopsied. A PSA value from 4 to 9.9 is usually biopsied, and there is an associated lower risk for developing prostate cancer with these levels, and that's usually about 20%. One thing to consider with an elevated PSA is the relation to the amount of time from the last ejaculation to the time that the labs were drawn, as this will elevate the PSA. It's recommended to have 48-hour in between ejaculation and the lab draw. Prostatitis will also elevate the PSA and thus needs to be ruled out as a causative agent for the elevation. Before tumor staging, using the tumor node metastasis system, a Gleason score on the biopsied tissue is first given by a pathologist. A score of 1 to 4 is likely to be slow growing, 5 to 7 is moderately differentiated, and 8 to 10 is aggressive and fast growing. The Gleason is based off the biopsy, and the tumor node metastasis system is based off the findings of diagnostic studies and/or findings during surgery. Stage 1 tumor is microscopic and not palpable, and it's not visible with transrectal ultrasound. At stage 2, it's a palpable tumor, but not beyond the prostate itself. Stage 3, the tumor extends through the seminal vesicles. Stage 4 is a fixed tumor that is spread far beyond the prostate itself. Treatment options include non-pharmacologic management, which would include surgical intervention of a TURP or a radical prostatectomy and orchiectomy, brachytherapy, which is the radiated seed therapy, cryotherapy or cryosurgery, radiation therapy, and watchful waiting. Leuprolide or Lupron decreases the amount of circulating testosterone, and this can be used for androgen-dependent tumors. Flutamide is an androgen ablation medication. It inhibits the uptake of androgen. Other options include estrogen therapy and chemotherapy. The prognosis of prostate cancer is relatively good, with a 5-year survival rate of nearly 100% and 15-year survival rate at 91%. Approximately 81% of patients with stage 1 or stage 2 local disease have a 100% survival rate after 5 years. 12% of patients with stage 3 or 4 regional disease without metastasis have an expected 100% survival rate after 5 years. And 4% of the distant disease or stage 4 with metastasis have a 28% survival rate after 5 years. For follow-up, referral to a urologist or oncologist to control disease progression. The patient should have a clinical exam to include a PSA every 6 months for 5 years and then annually thereafter. And the patient should have a chest x-ray and bone scan every 6 months for a year and then yearly. We should monitor for complications related to treatment, including phlebitis, cardiac problems, and hormonal changes that may lead to pathological fractures. Men treated with androgen deprivation therapy should be evaluated for cardiovascular disease and prevention. And for those choosing active surveillance as a treatment method, a prostate biopsy should be conducted 1 year after the diagnosis and then every 2 to 4 years after that to monitor. It is also important to screen for urinary and sexual dysfunction, as well as depression and anxiety in all of our patients with prostate cancer.